Hi everyone, welcome to Chapter 5. We are talking about adverse drug reactions. Our objectives are listed here. We're going to talk about the different classifications, risk factors for having an adverse drug reaction, and then the process of assessing for and detecting them. Okay? Our overviews are listed here. An adverse drug reaction is not an allergy. Okay? Allergies are part of adverse drug reactions, in the sense that an adverse drug reaction includes any undesirable or unattended effect, okay, after you take a drug. So yes, an allergy, like it gave me hives because I had a histamine release allergy to it, was an unintended and undesired consequence of having that drug. But it also includes things like nausea, upset stomach, I got dizzy, it gave me dry mouth. All of those things together are the unintended drug reactions. Adverse drug reactions cost America billions of dollars every year. The 2019 FDA data says that annually it's about 660,000 reported serious adverse drug reactions with 120,000 deaths. So in order to reduce the morbidity, the mortality, and the cost of these things, it's important for you as practitioners and prescribers to understand the causes and the mechanisms, and to have a good practice on how to evaluate for these and what you're going to do with them if you encounter them. Most adverse drug reactions are going to stop after you remove the drug. Some will stop after you decrease the dose of the drug. Unfortunately, there are some people that have side effects that don't stop after you have taken the drug. One of the examples would be like Accutane, so isotretinoin. That can cause the birth defects when used before or during pregnancy. That's never going to go away. Antipsychotics can cause tardive dyskinesia. That's never going to go away. So some of those things could be unintended permanent consequences. So adverse drug reactions, big deal. The mechanistic classifications of the ADRs, the book, how do we classify them? We can have pharmacological or we can have idiosyncratic. So we can have pharmacological, how the drug works within our body, and idiosyncratic, how our body works against the drug. Pharmacological reaction is often more predictable because it's based on the drug's mechanism of action. Like, we know that at certain doses, metformin really tends to give people diarrhea, so we start lower and go slower in titration, right? We know how some of these drugs work and what kind of reactions they cause the patients. However, the idiosyncratic reactions, which are unpredictable because we don't know when someone's going to have an immune-mediated reaction or a hypersensitivity, cell-mediated hypersensitivity reaction. Most of the adverse drug reactions actually are the pharmacological classification, meaning how the mechanism of action works with that drug can have that side effect or adverse reaction. At the base of idiosyncratic reactions typically is that those will occur, they're unpredictable, they tend to have more morbidity and mortality, and that is typically because the body has recognized the drug as something foreign, and attacked. Adverse drug reactions cost Americans tons of money, billions of dollars a year. They are associated with potentially mortality and high morbidity. So in order to decrease morbidity, mortality, and the cost that these events happen to cause, you as a prescriber then need to understand adverse drug reactions and how you're going to manage them as a prescriber. So, pharmacologic adverse drug reaction. Again, intrinsic, often exaggerated physiological response. They are often then, like we'd already talked about, managed by withdrawing the drug. And they could be occurring based on a secondary pharmacology. The idiosyncratic, meaning how our body is going to respond. Unpredictable, they tend to be dose related. They're often serious. These are the ones that will cause death, and they're mediated by either our immune system, our receptor mutations, drug-to-drug interactions, differences in a person's drug metabolism, pharmaceutical variations, and unmasking of a biological system variation. So we're going to break these down. Okay. Hypersensitivity reactions. We have type 1, type 2, type 3, and type 4. Your book does a great job in talking through these on page 49. The type 1 immune-mediated reaction, we think IgE type 1. It's an immediate type hypersensitivity, and it's provoked by re-exposure to an antigen. So a type 1 reaction is an acute hypersensitivity reaction that may be local or systemic. It can involve the skin, the bronchopulmonary system, the nasopharyngeal tract, the eyes, and the GI tract. It is caused when an antigen exposure induces the release of the mediators, right? Like histamine, leukotrienes, prostaglandins from the mast cells. So IgE mediated, we have mast cell involvement. The mast cells get triggered and they will release histamine, leukotrienes, prostaglandins. We also have actions of the basophils and the recruited inflammatory cells that then activate IgE. So most causes are mild, so we think of like allergic conjunctivitis, rhinitis, bronchospasm, urticaria, hives, or atopic dermatitis, but this also includes angioedema and anaphylaxis. Symptoms may occur immediately, within minutes, or be delayed several hours after the exposure. An example, acute anaphylaxis may occur after exposure to an antibiotic, or to neuromuscular blockers, or to some of the chemotherapy agents. Okay, we're going to go through those a little bit in detail. Oops, sorry, I was on this different slide. So again, when we think type 1, we're thinking mast cells, basophils, histamine, leukotrienes, prostaglandins. It's an acute hypersensitivity. It typically happens as a re-exposure to an antigen. This example is something like, maybe you got stung by a bee in childhood, you hadn't been stung by a bee in years, and then now you get stung as a bee 20 years later, and you have an anaphylactic reaction, okay? These are things that we typically treat with antihistamines, epinephrine, and corticosteroids. Type 2 is antibody dependent, okay? These can affect a variety of organs and tissues. So, in the bloodstream and on surface of cells, the antibodies will unite with the antigens or haptens and induce destruction of cells and tissues through the activation of the complement system or through removal by macrophages. Okay? So type 2 sensitivity, think antibody dependent, can affect any organ or tissue. The antibodies will unite with antigens or haptens and induce destruction of cells and tissues through the complement system being activated and through removal of or by the macrophages. Okay? They can occur within minutes to hours. Cytotoxic reaction. Think of things that are immune-mediated thrombocytopenia or drug-induced immune thrombocytopenia. This also includes our hemolytic anemias, neutropenia. Typically, these will improve with the removal of the drug and an anti-inflammatory or immunosuppressive drugs. Immune-mediated thrombocytopenia, ITP or DITP, is generally caused by medications but could also be from foods or herbal products. Most of these DITP reactions are associated with the formation of drug-dependent antibodies that bind to glycoprotein and cause an antibody platelet reaction resulting in thrombocytopenia. This could be maybe from Bactrim, as an example, or valproic acid. DITP or ITP can also occur when heparin binds to the platelet factor 4 proteins and forms an antigenic complex where IgG antibodies bind to the platelet. which is how you get the hemolytic anemia and neutropenia. So hemolytic anemia occurs when the drug binds to an antigen on the surface of a red blood cell, and this causes the complement activation, and that results in the cell lysis. Neutropenia, sometimes we call this agranulocytosis, can occur then when those antibodies unite with antigens on the surface of neutrophils. And then that same thing happens within minutes to hours, and we get the breakdown of the white cells. Think of drugs like, again, Bactrim can do it, ACE inhibitors can do it. Okay. Important to understand that it will typically improve with removal of the drug. You can have people with sudden drops in their platelet count or sudden drops in their neutrophils, agranulocytosis, and once you remove the drug, often it will get better, but sometimes you need anti-inflammatories, think steroids, or immunosuppressive drugs. Type 3 hypersensitivity reactions are immune complex, and these occur when aggregates of antigens and IgG and IgM antibodies create insoluble immune complexes in the vessels or the blood that may be deposited in tissues. So this is things we think of deposited, kind of these complexes that form in joints or kidneys as the examples. So this reaction takes place a week or more and may present as serum sickness, drug fever, or vasculitis. So let's talk about this. The example, one of them that the book talks about is the Arthus reaction, which is that local vasculitis reaction. And they give the example that after you get a TDP, or your TD vaccination, your tetanus diphtheria toxoid vaccine, you can get a local vasculitis, causes severe pain, swelling, edema, that indurated skin, hemorrhage, and possibly even necrosis. That's the Arthus reaction. The risk of the Arthus reaction from the vaccine is elevated when a patient receives vaccination more frequently than every 10 years. Because you're likely to get this if you have a high circulating number of antibodies. So as time goes on, your antibodies total decrease, and that's why you don't get this shot like every 10 years. But if you've had the reaction, it is 10 years. Otherwise, it's, typically 3 to 5 years. We think about getting that again. They can cause then arthralgia, swollen joints, swollen lymph nodes, or even an enlarged spleen. And you treat them with antihistamines and anti-inflammatory drugs. Your type 4 hypersensitivity reactions are cell-mediated, and they're delayed. So 2 to 3 days up to weeks. Type 4, in my mind, I always go straight to Stephen Johnson, or the different skin things. That's how I've always remembered it in the past. These are a result of the autoimmune and infectious diseases or contact dermatitis. The toxic epidermal necrolysis is also a terrible thing once you see it. We have this thing called drug-induced hypersensitivity syndrome, which is DIHS. It's a severe reaction that can cause a rash, but also is associated with really high fevers, eosinophilia, and infilling. It also, in the past, has been called DRESS, which is how I learned it back in the day, which is drug, rash, eosinophilia, systemic symptoms. These can be examples that can cause the DRESS. Could be something like allopurinol. Stephen Johnson syndrome has been associated with a gazillion different types of drugs, but there are some that are more common than others. So we have them idiosyncratic are 1 through 4, type 1, type 2, type 3, type 4. To review, type 1, think IgE, think angioedema, anaphylaxis. Type 2 is antibody dependent, and think of things like thrombocytopenia. Type 3 is where you get the immune complex hypersensitivity, like an Arthus reaction to your tetanus. And then type 4 is cell-mediated or delayed. This is Stevens-Johnson's, this is stress, this is eosinophilia. We also can classify the ADRs in types A through F as listed here. The other way we can classify drug reactions, adverse drug reactions, is by the time. Okay. So we can have immediate or we can have delayed reaction. Typically, to have immediate, the definition is it occurs within 1 hour after exposure, whereas a delayed reaction occurs typically an hour or more after exposure. And then we can even break that down into rapid, first dose, early, intermediate, late, or delayed. Too soon. So rapid means immediately after the administration. So these are unintended reactions occur when their medications administered improperly or not necessarily associated with the first dose. So this could be like people that get vancomycin can get a macular papular rash on their face, neck, and trunk because the drug's being given too rapidly. Phenytoin, which is dilantin, can cause an adverse reaction known as purple glove syndrome, which is blood vessel irritation and inflammation when administered peripherally. The next one was the first dose reaction, and that occurs after the first dose. For example, orthostatic hypotension is a common reaction after the first dose of doxazosin, and generally does not occur with repeated doses. So obviously it's important to understand that because we could tell people it gets better, you will keep taking it, etc. Early reactions occur early in the treatment and resolve with continued treatment as the patient develops a tolerance. So we don't necessarily need to discontinue the drug, but we have to give the patient time to adapt to the medication. Often in these scenarios, we go with a really low starting dose and sequentially titrate upward to mitigate the severity and duration. Okay, this is the examples the book gives are two classics: SSRIs and metformin. Okay, you start low and you go slow to up titrate to mitigate these early reactions. Intermediate reactions occur after repeated exposure to a medication. They're difficult to predict. Late reactions occur after prolonged exposure to an offending agent. So you could, the example, a great one is steroids. You could be taking steroids for a long time, and then eventually you start to see those unintended adverse drug reactions to include the thinning of your skin, maybe easy bruising, hypergonadism after prolonged use. Late reactions also would include then if you go through withdrawal of a drug. And then delayed reaction occur at a variable point in time after the drug exposure and can even still occur after you've stopped the drug. Dose-related drug reactions are when you have an excessive dose or failure to adjust the doses properly for age and organ function. Severity of your adverse drug reactions is based on the clinical effect and the outcome. So the FDA defines our serious adverse drug reactions as those that result in death or were life-threatening, or disabling, incapacitating, or required hospitalization. Then you can further say the severity could be categorized as mild, moderate, or severe. When they're mild, oftentimes you can adjust doses, those kind of situations. So common causes overview. We have genetics, age, sex, drug interactions, medical conditions, and your body mass. let's go through those. Genetic factors affects the body's ability to metabolize drugs. So we've learned this in your pathophysiology. There are people that are born with different genetic mutations or lack cytochrome markers and different things that allow them to even metabolize a drug. They can contribute to the pharmacological and our idiosyncratic reactions, and they may alter the concentrations of the active, inactive, or potentially toxic drug products. One of the main ones we have to worry about is malignant hyperthermia, and that can result after administration of general anesthetics. Genetics also can increase the likelihood of hapten-induced hypersensitivity reactions. The other example that they talk about is people of the Han or Han Chinese descendants who express HLA-B, or some of those alleles, they're at higher risk then of the hypersensitivity to reactions for certain drugs. Okay, then age. Obviously, they make a difference. We dose things based on age. We know this. Children and older adults then are at higher risk of experiencing an adverse drug reaction. Children, because medication dosages must be tailored to their body weight. Inattention to weight-based dosing can cause serious harm. Also, depending on how young the person is, like an infant or a neonate can have immature organ function. When we talk about older adults, typically we're talking 65 and older. We have to start thinking about decreased renal and hepatic functioning, which then causes decreased metabolism and clearance. People are at risk as older adults to be hospitalized due to unintentional overdoses. Sex or gender, women have more adverse drug reactions than men, probably due to differences in body composition like our drug distribution, pharmacokinetics, and our hormonal fluctuations. And then we know we can have our own ADRs related to pregnancy and lactation. Drug-drug interactions are such an important thing. We have come so far in our studies and our science of drug-to-drug interactions, which is great. However, as people live longer, they live with longer diseases that are more chronic, and we're getting into advanced elderly ages, people are going to be on multiple medications. And when we start to worry about the possibility of even small drug-to-drug interactions, it's really challenging of where do you cut off the line. So if somewhere in the literature there was 1% of people that took these two drugs experienced something, and you get dinged on that every time that you go to order the drug, it can become really disconcerting. And so to me, part of the frustration is I love that we're in an electronic world that can help me understand drug-to-drug interactions because so many people are on so many different drugs. However, we have to find, in my opinion, a balance of when do we draw the line of when we should report that to people or not. Because you get this ding, and then you click on the little information tab and you go deeper into it, and you're like, this was like less than 1% of the people that took these two drugs. Like, I have to take into account, I don't have good options. These are the drugs we need. These are the drugs I have available. I'm going to use them. So this is something you'll see in practice. But we do know that there are some serious drug-to-drug interactions that we have to worry about. One of the things that comes to mind easily is warfarin. We know that if your person is on warfarin and you start adding drugs, you have to check for drug-to-drug interactions, because that can alter the way that the body metabolizes the warfarin, or it can even make the INR go way too high, the INR go way too low, and that can be very dangerous. So a drug-to-drug interaction is something we definitely have to take into account. We are blessed, like I said, by electronic records, and we have a lot of these screening tools built in. This also includes not just drug-to-drug, but also food and timing, right? So it is really important to pay attention to instructions of whether or not it should or should not be taken with food. It should or should not be taken with 8 ounces of water. We have specific instructions on how to actually take and use the drug the appropriate way. Most drug interactions are not clinically significant, but there are those common ones that are, and we learn these as we go through the different body systems and drug treatments. Okay, people with renal and liver disease, we should always think about and checking to see if we need dose adjustments for those. Pregnancy is a whole different ballgame, and how we do that as well, and we talk more about that further down the course. So, drug or drug combination that are suspected of producing the adverse reactions are frequently identified by screening of pharmacists. It is important to remember that almost 90% identified drug interactions will not have clinical consequences for an individual patient, but do represent a warning to monitor the patient for the potential problems. A smaller number, the book says perhaps 2%, of identified drug interactions will then be the ones that do have that profound or serious clinical consequence. The challenge is that individual adverse reactions can present in patients without warning as well. So it's really difficult. We now know, because we finally caught up, that pharmacists are invaluable people in the hospital. And now having pharmacists on the floor, at the bedside, rounding with providers, on the trauma team, on the code team, on the rapid response teams, because they facilitate so much and they help with so much knowledge that we finally figured out we integrate the pharmacists and we get much better outcomes. You, in my opinion, will always be better served by making friends with your pharmacist. It can be difficult to determine causality, and that's the really hard thing, right? If you're taking 6 medicines and you get an adverse drug reaction, how do you typically actually say it's this medicine, right? Because it could be delayed, it can be weeks later, hours later, days later. It's really challenging. One of the first rules of thumb is you don't want to start a lot of medications at the same time because you don't know which drug could be causing a reaction if they had. So, what do? Many drugs suspected of causing these adverse drug reactions should be promptly discontinued if the offending drug can be safely stopped, if the event is life-threatening or intolerable, or if continuing the medication would worsen the patient's condition. But there also has to be a reasonable alternative treatment available. There are times that you have to continue a drug because it is medically necessary and there is not an alternative that is acceptable. So sometimes we give these drugs and we say you have to grin and bear it. You got to grit your teeth and get through it. We don't have any other options here. Those are hard situations, but you as acute care providers are going to see them more than maybe your family practice. There are going to be times when you have to do that. You've heard probably that with penicillin, back in the day, the penicillin allergy was actually the agents that they used to mix the penicillin with to deliver. That's what people were allergic to, not truly the penicillin. So oftentimes, if you are in an acute situation where you have a really bad bug and you need to give a penicillin, and they said, well, they're 70 years old and they tell you in childhood, I had a bad rash and they told me never to take penicillin again. We would actually challenge them with penicillin and do a testing to see if that was truly the case or not, because we're in a pickle and we need to use those drugs. We have the Naranjo probability scale. It's a framework for assessing the probability that an ADR is related to administration of a particular drug. It looks at timing, history, re-challenges, alternatives, dose dependency, a lot of different things. It's actually shown in Table 5.3 in your book. So it is something to think about as a resource to you as a prescriber. Remember, we've already spoken about the different phases that a drug has to go through. Remember that once it is released and it's approved to the general populace, we still have post-marketing surveillance, and it is incredibly important that we as prescribers pay attention to this, because we have to help, report post-marketing some of these adverse drug reactions that we may see. The book even says we have an obligation as prescribers to provide data to allow the FDA to monitor the safety of drugs and of vaccines. The FDA maintains the Adverse Event Reporting System, which is FAERS. It's a computerized database of adverse events for these drugs or biologicals. MedWatch is the FDA's safety information system, and it has the reporting program that provides us as providers and healthcare professionals with medical product information on prescription and non-prescription drugs, including medical devices, biologicals, and other nutritional products. And we also have the Vaccine Adverse Event Reporting System as a separate program specific to vaccinations. It's like MedWatch, and it allows voluntary reporting of adverse events by both healthcare professionals and the consumers. So it is our obligation to participate in this, because this is how we get the data to know how we can safely and best care for our patients. Okay. In reality, adverse drug reactions are something that we're going to see. They happen. They are preventable in some situations, and sometimes they're not. They're idiosyncratic, and we don't know who's going to be allergic to what. When you are willing to prescribe something, sooner or later, you are going to give somebody a drug that causes a reaction. It takes 12 years off your life. You're always fearful that you've done something incredibly wrong. But at the end of the day, as the more and more medications you prescribe, the law of, science says eventually you are going to be the one that prescribes a drug that gives an adverse reaction. It's okay. You have to be diligent and do all the steps that you can do to mitigate the risk the best you can. And if you've done that, then it is what it is. So remember, as a provider, we need to think about drug-to-drug interactions. We have to have a correct medication list to work with. We are blessed because we have electronic databases that can help us. We plug in the drugs, we type in the drug we want to give, and up pops potential drug-to-drug interactions. We can mitigate the chances of having ADR by thinking about age, genetic factors, risk factors like their age, their medical conditions, those types of things. Take all of that into account. You can reach out and phone a friend, which is your pharmacist. Pharmacist will always help you. If you say, I have a concern, can you help me walk through this? Which drug would be the best to give? So on and so forth. We have obligations to participate in post-marketing surveillance and reporting of symptomology. I'm going to take a brief moment here to go on to my soapbox because it fits in again well here. Medication reactions and medication errors, I want to say, although it's not an adverse drug reaction, it plays into this, okay? Medication reconciliation is an incredibly important step in healthcare delivery. And I can tell you through my years, it's incredibly challenging to perfect this system. It is faulty everywhere I've gone. People struggle with how, especially in acute care or outpatient, how are we going to get accurate medication reconciliation? When that is not done correctly is oftentimes the root cause analysis finding is that we had a bad medication reconciliation. So this also plays into adverse drug reactions. If I don't know that my patient is taking certain drugs, I'm going to increase the risk of adverse drug reactions, right? So when you are out in practice, Whether it is you are in an outpatient heart failure clinic, whether you're a CNS, whether you're an NP, whether you're in a trauma unit, it's crazy busy, no matter where you are, you're, the heart failure team, whatever the case may be. I strongly, strongly, strongly encourage you to build into your way that you practice and care for patients, to build in a checkpoint, if you will, of medication reconciliation. I would say be anal about it, right? I would encourage you to be so anal about it that you staff members that you work with are going to be like, oh my God, Sarah is going to flip out because I don't have a med rec on this patient. She's really, really anal about it. Okay? That is what I strive to be. I want the people that work with me and on my team to know, please do not bring me a patient without exhausting every attempt at obtaining an accurate medication reconciliation. Okay? So much of what we do stems on that information piece. And like the saying goes, if you put poor data in, you're going to get poor data out, right? So if you put in poor medication reconciliation into your steps of practice, you're not giving good practice. It's just not going to happen. People overdose, people take the wrong medications, people double dose medications. I've had people be on metoprolol succinate as well as metoprolol tartrate, and the patient didn't say anything because, well, the labels were different. They figured their provider knew what they were talking about. All sorts of different things, okay? There were people that take medications that weren't supposed to get refilled but accidentally got refilled. Or people bring a list to you and it's got 20 drugs on it when in reality they're not even on half of them anymore. So all of those things come into play. So at some point, please, please, please impact your work environment to obtain an accurate medication reconciliation process or practice. When we're inpatient, I've seen it a variety of ways. I've seen the pharmacist come into the ER and they're questioning the patient before they go up to the floor, trying to get the right med list. I've seen a charge nurse, that's an admitting charge nurse, or but an assigned nurse to admissions, and they go around in the major ER, and everybody that's scheduled to get admitted, they go around and ask for the med list, and they call the pharmacy and they try to hunt it down. I've seen standard protocols on a hospital that you cannot admit a patient until you check a box that says you have verified it and to the best of your ability tried to obtain a med rec. I've seen people where you can't do their discharge because the EMR or the EHR tells you can't discharge somebody because nobody verified their home med rec. There's a lot of different ways that people do it. Some people send the pharmacist to the floor. Some people have access to all of the EMRs in the area and some places don't. So there's a variety of ways that people handle the med rec process, especially through a hospital health system, but it is fraught with errors. So I'll get off my soapbox for a minute, but if you want to talk about mitigating adverse drug reactions, one of the critical steps in that is going to be knowing what drugs you're working with in the first place. Nothing is more irritable than not realizing the patient was on a blood thinner. And they didn't tell you, their wife didn't tell you, their spouse didn't tell you because people just forgot. Or people didn't know, rivaroxaban's a blood, it's an anticoagulant. What? Well, I didn't know that. He's been on that for like 2 years. Well, why? Well, a long time ago he had a clot in his leg. Well, okay, people were accidentally kept on a drug or whatever the case may be. I mean, think about it if you sent someone down for a lumbar puncture and you didn't know that they were on Xarelto, right? Talk about an adverse drug reaction or possible setup for those things. Or if you give somebody, TPA and you didn't realize they had, a contradiction going on, those kind of things. So that's my soapbox. Please, 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 please remember that you had a really annoying pharmacology professor that told you, please, 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 please pay attention to your med recs. Okay, couple of knowledge checks. Which of the following statements corresponds to a type 2 hypersensitivity reaction? Okay, so we're thinking type 2 now. Is it antibody-dependent, immune-mediated, an immune complex, or cell-mediated? Type 2 hypersensitivity reactions are the antibody-dependent cytotoxicity that can affect a variety of organs and tissues. These are things like drug-induced immune thrombocytopenia. Which of the following most comprehensively reflect the risk factors for adverse drug reactions? I'll let you read the screen there. This is a pretty straightforward question. And the answer is A. So our risk factors we talked about include genetics, age, sex, polypharmacy because of the risk for drug-to-drug interaction, and concomitant medical conditions. And you guys have made it through chapter 5, and we will see you in chapter 6.